Sir, President
Yeah.
sir, you start.
Yeah, it's time 6 o'clock. Dear all, good evening. Welcome to the 21st edition of Pudukkottai Budan, an online weekly academic program from Pudukkottai ISA City branch, a branch of the state, Tamil Nadu State ISA branch. Our Honorary Secretary Dr. Periyasamy is waiting in the line for he will propose the welcome address. Over to
Thank you,
Dr.
sir.
Periyasamy.
Thank you, sir. Respected Academic Chairman Dr. A.L. Minachandram, sir, President Dr. Suresh Kumar, sir, Treasurer Dr. David, and member of ISA Pudukkottai, delegates of this special program of Pudukkottai Budan. On behalf of ISA Pudukkottai, I welcome you all for this webinar online program of 25th program, 21st program, I think so. I welcome once again. I welcome you all for this program and for your and I thank all you for your continuous support for success of this program every week of this Pudukkottai Budan. And before going to the program as such, our best wishes for SARC Anesthesia Conference, which is going to be held in Kerala, Cochin this week. Continuously, we are conducting program on every Budan of every week. These are the topics which are already covered by Pudukkottai Budan programs. This is the 21st program. Last week we discussed about anesthesia management of bronchopleural fistula, lung function test, and eye gel. This week we are going to have a topic about eye surgeries. For that, we are having Chairperson Dr. Rajesh Diwan, Medical Director, Ragdeep Eye Hospital, Ahmedabad, Gujarat. I welcome you, sir, on behalf of ISA Pudukkottai. As speakers, we are having three eminent speakers from various parts of the country. First speaker, Dr. Jayachandran B.V., Deputy Director, Sangara Netralaya, Chennai. Sir is going to talk about local anesthesia technique for intraocular surgery. I welcome you, sir, on behalf of ISA Pudukkottai. Next speaker, we are going to have Dr. Renu Simka, Professor, All India Institute of Medical Science, New Delhi. Madam is going to talk about anesthetic management of a child posted for strabismus surgery. I welcome you, madam. Next speaker, Dr. Anusha Bharatam, resident, Jahangir Hospital and Research Center, Pune, Maharashtra. Madam is going to talk about intraocular pressure. We welcome you, madam, on behalf of ISA Pudukkottai. Next, this program is accredited by Tamil Nadu Medical Council for credit hours. These are the details. Those who want to apply for credit hours, you have to pay 100 rupees to our account. The account number is mentioned here. You can note it down. And those particulars have to send to isapudukottai@yahoo.com mail ID. With this small poem about eyes making the meaning of world and packing the life with the colorful rays. Individualization and insight, everything evolved in our eyes. Figures are penned and beauty of world framed by our eyes. Lights are colorful and life becomes meaningful because of our eyes. Our mission are successful. This Pudukkottai mission are successful because of our vision of grateful, because of our academic chairman. I think because of our academic chairman, our vision are grateful. Let us this lesson with love and passion. With this, I thank you all for this opportunity. Thank you, sir. Over to President.
Dr. Suresh, unmute yourself.
Thank you, Dr. Periyasamy. Dear Secretary, Treasurer David, our respected Dr. A.L. Meenachi Sundaram sir, Academic Chairman of our ISA Pudukkottai City Branch, office bearers and members of ISA Pudukkottai City Branch, dignitaries assembled here, and our speakers and chairperson, postgraduates. On behalf of ISA Pudukkottai City Branch, I once again welcome you all. It is an academic rain from Pudukkottai City Branch every Wednesday, all because of our academic chairman, Dr. A.L. sir. Every week we have one topic, wide variety of speakers from all over India, which we cannot even witness in all India ISA conferences. Wide choice of speakers and immensely useful for postgraduates in two ways. One, every postgraduate is participating in our webinar, and all the postgraduates can take home message by having variety of topics, even which cannot be taught in their academic curriculum. So on behalf of ISA Pudukkottai City Branch, I thank you and welcome everybody here, especially our chairperson, Dr. Rajesh Diwan, and speaker, Dr. Jayachandran VV, Madam Dr. Renuga Shinka, and Madam Dr. Anusha Bharadam. And I hand over the proceedings to our academic chairman, Dr. A.L. sir, to conduct the webinar. Thank you. Over to Dr. A.L. sir.
Thanks, Mr. President. Respected Dr. Rajesh Diwan sir, Dr. Jayachandran, Dr. Renu Sinha madam, Dr. Anusha Bharadam, and the distinguished delegates attending this webinar. At the outset, I say good evening to all of you, and I am really overwhelmed today by the speakers, because even though we have conducted so many webinars, this webinar is peculiar, and I don't think when it will be repeated again, because it is different in three distinguished areas. One, it is dealing with the smallest area possible, that is ophthalmic anesthesia. So far, we have discussed about general anesthesia, regional or large organs. This time, we are discussing about the smallest organ possible. That is number one. Number two, this is the first time the four faculty are from four different areas. So far, it has not happened like that. One is from our home state, Tamil Nadu. Another one is from Gujarat. One is from Delhi. Another one is from Maharashtra. I don't know when it will going to happen again. And the best part, the third part is all are international faculty. These three, because he is a resident, this is the first time it is happening like that. Every time we will have one or two, but at this time it is a peculiar. All the people are international faculty, and Dr. Anusha, resident, is really fortunate to share the podium. I think this may be the first lecture for her. And for Dr. Anusha, we thank Dr. Pratibha Kane, her professor and HOD, who has groomed her to talk about intraocular pressure. And today we are happy to have Dr. Jayachandran from Tamil Nadu. He is a deputy director of Shankar Netralaya, and everyone knows he is a pioneer in starting this ophthalmic anesthesia. I know many years back he used to struggle to seek people's support for this ophthalmic anesthesia forum. He used to pesturize everyone. Sir, ophthalmic is a different one. Ophthalmic is a different one. And at last he has succeeded. And I am happy to say he is the founder secretary of Association of Indian Ophthalmic Association. That is a great honor. With his continuous persuasion, he has done that. And another happiest part is he is the president of World Congress of Ophthalmic Anesthesiology for 2024. So he's going to take over the chair as president for World Congress of Ophthalmic Anesthesia in 2024, and he is the president International Association for Healthcare and Data Analytics. So we are happy to have Jayachandran from our home state, Tamil Nadu. That is a best part. So I welcome Dr. Jayachandran on my personal behalf, because he has been a friend to me for more than 15 years. Then Dr. Renu Sinha, she is a professor in All India Institute of Medical Sciences, and she is the editor of Indian Journal of Ophthalmic Anesthesia. That is the reason I am saying all are best part. She is the editor of Indian Journal of Ophthalmic Anesthesia, and she has more than 100 publications in index journals. And she has written several chapters in ophthalmic and pediatric anesthesia textbooks. She is also an international faculty in ophthalmic anesthesia. And Dr. Anusha Bharatam is a resident in Jahangir Hospital, Pune, and she did her undergraduate in Regaraya Medical College, Kakinada, Andhra Pradesh. So in that way, she is representing two states, Andhra Pradesh as well as Maharashtra. She is groomed by Dr. Pratibha Kane. Then, as I used to say, we are very particular about the chairperson for every webinar. This time, we are having the topmost person in ophthalmic anesthesia, a nice gentleman who is soft-spoken by name, Dr. Rases Diwan. And here I want to say, I asked Dr. Rases Diwan and I asked Jayachandran, whom do you want to have as a chairperson? Then he has sent me a message, Dr. Rases Diwan, if he is there, it will be nice. Already he has been fixed. So after 5 minutes, I have sent a message. I have fixed Dr. Rases Diwan. So great people think alike, but I don't know how I thought alike Dr. Jayachandran, who is a great man. Sir is a past president of Ahmedabad city branch, and he is a past president of Gujarat state branch. And in 2021, Isakan, Sir was the organizing chairman. He has become more popular. Already he is popular in ophthalmic part, but he has become more popular in Indian Resuscitation Council because he is a national course director. Whenever we want to prepare any video on Indian resuscitation forms, it has to be approved by SAR only. So he is a course director for Resuscitation Council, and he is a reviewer for I, which is a international journal. So his I should be on the research papers submitted to I, and he is a faculty in International Ophthalmic Anesthesia Forum, and he is a co-author in many textbooks, ophthalmic and anesthesia textbooks. He is a DIPNB guide. More than that, he is a medical director for Ragdeep Eye Clinic. So without him, I think that the ophthalmic anesthesia symposium cannot go beyond certain stretch. So we have the best person as a chairperson, and he was ready. When I contacted him, he said, I am willing to take part, and he was asking whether Dr. Jayachandran is participating or not. That is the fun, because these people are the selected creamy layer in ophthalmic anesthesia, and really Pudukkottai Anesthesiology City Branch is honored to have the topmost people, and without having anything in mind, they volunteered and they readily accepted. So for their simplicity, I bow my head for all the 3 international faculty, and that postgraduate, Dr. Anusha, who is fortunate to share the platform, and she has to thank Dr. Pratibha Kane Madam for everything. And usually we hand over by 6:20, before 6:20. Now it is 6:14. I hand over the podium to the chairperson, Dr. Rases Diwan. Sir, it is your time. Thank you.
Thank you so much, Dr. L. Meenakshi Sundaram, the President, Indian Society of Anesthesiology, Pudukkottai branch, and the Secretary, the office bearers, and my beloved academic chairman, Dr. Meenakshi Sundaram. I owe a lot to you. The words you used for introduction, I think something very great. And I was overwhelmed. Is was really necessary or not? But one thing is that, as you said correctly, the like-minded people always stay together. The first question I asked when you asked me, I give the name of these two people. So that is how we are together, and we've been working for Officer for many, many years. And I would say my younger friend Jayachandran is the leader, and we all work under the leadership of Dr. Jayachandran. So very much thankful to him too. Before actually you're giving me 3 minutes more to introduce, let me tell you the ophthalmic anesthesia. I started in 1989, and probably I was the first to start the peripulbar technique in our country and started teaching the ophthalmologists how to give peripulbar technique. And that was a different time that time. But let me tell you, this subspecialty has been taken over by the anesthesiologists. Till that time, all the regional anesthesia was done by the ophthalmologist only. But ever since then, nationally as well as internationally, the subspecialty of ophthalmic anesthesia, particularly regional, has been taken over by the anesthesiologists in most of the best centers in our country as well as in the world. And I'm sure our PG postgraduate students are listening. You need to pick up this, you need to learn the techniques well. And I'm sure it's a very, very useful specialty to put in your armamentarium. And it's going to be very useful in the life. So I will not waste much time. Thank you so much for inviting me. And we start with the first lecture. And I would like to invite first our postgraduate speaker, Dr. Anusha. Are you ready? I can see your slide.
So can you hear me?
Yes, very well. Thank you so much. And she's going to talk on the intraocular pressure. And let me tell you, this is 21st program, but it's a wonderful thing the Pudukkottai city branch is doing is for the training of the postgraduate students. Because I was going through the chapters and the lectures and the topics you have covered, they all are as a part of the examination they get in the postgraduate curriculum and examination. So it's a wonderful gesture in the benefit of the postgraduate students. Yes, Anusha, please go ahead.
Good evening, everyone. I'm Dr. Anusha Baratam from Jahangir Hospital. I would like to thank Dr. Meenakshi Sundaram sir and Pudukkottai Badan for this opportunity to present my topic, intraocular pressure. Coming to the definition of intraocular pressure, it is the pressure exerted by the intraocular contents on the layers of the eyeball. Normal intraocular pressure is about 16 plus or minus 5 mmHg, amounting up to 12 to 20 mmHg, which is this range throughout life and in both sexes, although there may be slight seasonal or diurnal variations. Values greater than 25 mmHg is considered pathological. Intraocular pressure is mainly generated by the presence of aqueous humor. 80 to 90% of aqueous humor is actively secreted from the ciliary body, mediated by sodium and potassium ATPase and carbonic anhydrase enzymes. The remainder is secreted by passive filtration and ultrafiltration by the ciliary processes. So, as you can see in this slide, aqueous humor is secreted by the ciliary body, and in the posterior chamber, it enters the anterior chamber through the pupil, and here it is secreted by two outflow tracts, that is a trabecular outflow and uveoscleral outflow. 75% of this aqueous humor passes through the trabecular meshwork through the Schlemm's canal and deposited in the episcleral veins, which we call as a trabecular outflow, while the remaining 25% passes through the ciliary body through the suprachoroidal space, enters the venous circulation of the ciliary body and sclera and orbit, which is called the uveoscleral outflow. We measure this intraocular pressure by using a tonometer. There are two types of tonometers. One is an applanation tonometer and another is an indentation tonometer. Applanation tonometers comes in various forms. There are various examples, and the gold standard is a Goldman applanation tonometer, and the modification of this Goldman applanation tonometer is a Perkins tonometer. Example of indentation tonometer is a short tonometer. What is the significance of intraocular pressure? Normal intraocular pressure is necessary to maintain corneal curvature and proper refracting indices of the eye. The intraocular perfusion pressure, which is defined as the difference between the mean arterial pressure and the intraocular pressure, regulates the blood perfusion to the eye's internal structures. Any increase in this intraocular pressure causes a reduction in the intraocular perfusion pressure, thus impairing blood supply to retina and optic nerve, eventually resulting in loss of optic nerve function, causing blindness. There are various anatomical and pathological features of the orbit that influence intraocular pressure. These are broadly classified as intraglobal or extraglobal features. Intraglobal features, these include aqueous humor volume, blood volume, foreign bodies like sulfur tetrachloride, which we use in vitreal surgeries, tumors, hemorrhage, intravitreal hemorrhage, vitreous humor volume, and scleral rigidity. Coming to the extraglobal features, those are the anesthetic regional blocks, extraocular compression devices like Hannon balloon, extraocular muscle tone, scleral strapping, retro or perivulvar hematoma, abscess or tumor, face mask, and positioning. Factors which causes rise in intraocular pressure, they are classified as physiological factors. These are a normal blink increases the intraocular pressure by about 10 mm of mercury, while a forceful lid squeeze can increase intraocular pressure to more than 70 mm of mercury. There were various ocular causes, and the most important one is a glaucoma, which may be an acute angle closure or a open angle, that is a chronic open angle glaucoma. The other ocular causes are iris swelling, displacement of the iris, extrinsic compression, that is, it may be during the position of the patient, or the compression given by the ophthalmologist after introducing a perivulvar or retrovalvar block, and squeezing the eyelids shut can increase intraocular pressure up to 50 mm of mercury. Arterial pressure regulates the choroidal blood volume, and any changes in this choroidal load volume causes changes in intraocular pressure. A rise in mean arterial pressure may also cause a detrimental increase in intraocular pressure, especially in open surgeries. External compression via face masks and endotracheal tube ties may impede venous return if forcibly applied. This may cause a retrograde increase in intraocular pressure. Coughing, straining, vomiting can increase intraocular pressure up to 30 to 40 mm of mercury. Steep Trendelenburg position increases intraocular pressure by an average of 13 mm Hg, higher than pre-induction values. Prone position is also a determinant factor for increase in intraocular pressure. Laryngoscopy, endotracheal intubation, Ryle's tube insertions are the various procedures where intraocular pressure increases during induction. Factors which reduces intraocular pressure are head-up position reduces venous return, thus reducing choroidal blood volume and decreasing intraocular pressure. Lowering arterial blood pressure reduces intraocular pressure, and while systolic blood pressure less than 90 mm mercury is recommended in open eye injuries. Effect of various anesthetic agents on intraocular pressure. We use a variety of drugs during surgery, and all the inhalational agents, intravenous anesthetics, and non-depolarizing muscle relaxant decreases intraocular pressure, while except muscle relaxant succinylcholine, which increases intraocular pressure by 8 to 10 mm of mercury for about 15 minutes after giving. All the diuretics like mannitol and acetazolamide decreases the intraocular pressure, which we use therapeutically to reduce intraocular pressure before surgery. Coming to the anesthetic management to reduce intraocular pressure. Preoperatively identifying patients which are higher risk, like example, patients with glaucoma, high myopic, is a must before starting a surgery. Care to avoid after induction and during induction, care to avoid exerting pressures on eyes with face mask during pre-oxygenation helps in reducing intraocular pressure. propofol and fentanyl are preferred for induction, as ketamine is not at known to decrease or increase intraocular pressure. Rocronium is preferred to succinylcholine. Intubation after complete relaxation and deep planes to avoid coughing and barking. And methods to reduce intraocular pressure during laryngoscopy by giving IV lignocaine 1.5 mg per kg 90 seconds prior to intubation is helpful. Head up position at laryngoscopy also helps in reducing intraocular pressure. All volatile anesthetics reduce intraocular pressure and can be used during maintenance of anesthesia. Maintain deep anesthetic planes to avoid movement of the patient. Avoid bucking at extubation, as bucking, coughing, and straining during extubation results in increasing intraocular pressure. Postoperative nausea vomiting can cause detrimental rise in intraoperative pressure. So, use of antiemetics like metoclopramide and dexamethasone for prevention of postoperative nausea and vomiting is indicated. And I'd like to conclude that for all anesthetic, it is all about pressure.
Can you mute other people? Dr. Viresham, good evening. Can you mute yourself?
ఎన్నో మర్చిపోతున్నావు నీ తాళంతే నా తాళంతే నేనే
Dr. Viresham, good evening.
Yeah, good evening, sir.
Thank you so much for joining. But I am fine, but would you mute yourself because there's a lecture going on?
Yeah.
Yeah, thank you. Thank you so much. And Dr. Anusha, it was a wonderful narration. I am sure any postgraduate students who has listened to your lecture can get 10 out of 10 marks in the question asked on intraocular pressure control during anesthesia and the pathophysiology of intraocular pressure. It was a very good lecture. There will be some questions in the chat box, but before that, we finish other two lectures. So now I invite Dr. Jayachandran. He's going to talk on the intricacies of the regional anesthesia in ophthalmic blocks.
So my slides are seen, no?
Yes, visible and audible both. Go ahead.
So at the outset, I would like to thank our president, Dr. Meenakshi Sundaram, for having given me this opportunity, and also the other office bearers of Pudukkottai ISH City branch. So the topic given to me was local anesthesia techniques for intraocular surgery. The reason is this is a question which many times that has been repeatedly asked in the postgraduates examination. Now, this is how I thought I will approach this topic. First, I will be talking briefly about the anatomy of the orbit as well as the globe. What are the different techniques used for ophthalmic anesthesia regional, and what are the complications occurring following local anesthesia, and briefly its management. Orbit as such is made up of 7 orbital bones. As you can see here, the roof is made up of orbital plate of the frontal bone. This is the greater wing of the sphenoid. This is the lesser wing of the sphenoid. And in between these two, this is the superior orbital fissure. At the apex, you can see the optic foramen through which the optic nerve emerges. This is the medial orbital wall, which is in turn formed by the orbital plate of the ethmoid, lacrimal, they are the palatine bone. The floor is in turn formed by the maxilla and the zygoma. And this is the inferior orbital fissure between the maxilla and the zygoma. The lateral wall, which is said to be the thickest of all, is formed by the greater wing of sphenoid hair and the zygomatic arch. This is the orbital anatomy. Orbit is an irregular 4-sided pyramid, and the base is anteriorly placed. Apex is posteromedially. The depth is about 40 to 50 millimeter. And here is the superior orbital fissure between the two wings of the sphenoid. This is the optic foramen through which the optic nerve emerges. And this is the inferior orbital fissure between the zygoma and the maxilla. The total volume of the orbit is 30 cc roughly. Coming to the anatomy of the globe, the horizontal diameter is said to be roughly around 23.5 millimeter. Anteroposterior diameter is about 24 millimeter. Vertically, it is around 23 millimeter. The volume of the globe is around 6 to 6.5 ml. So volume of the orbit is 30, whereas the globe is only 6 to 6.5 ml. The globe as such is moved by 4 recti muscles, that is the superior rectus, inferior rectus, lateral rectus, and medial rectus, and also the 2 oblique muscles, namely the superior oblique and the inferior oblique. As you can see in this picture, all these extraocular muscles, they originate from the annulus of Zinn here. It is a fibrinous tendinous ring at the level of the optic foramen. And you can very well appreciate in this picture, all these extraocular muscles, they come forward and they get insert just anterior to the equator of the globe, forming an incomplete muscle cone-like structure. With regard to the motor nerve supply, the most important motor nerve is third cranial nerve, oculomotor nerve, which supplies the superior rectus muscle, inferior rectus, medial rectus, inferior oblique, and levator palpebrae superioris, which helps to elevate the eyelid, upper eyelid. When coming to the motor nerve supply, it is important to remember the mnemonics LR6 SO4. What is it? That is, sixth cranial nerve, abducens, supplies the lateral rectus, whereas the fourth cranial nerve, trochlear nerve, supplies the superior oblique. So these 2 points you should remember. When coming to the sensory nerve supply, the most important nerve is the nasociliary nerve, which is nothing but an ophthalmic branch of the trigeminal nerve, which supplies the sensory fibers through the ciliary ganglion, which is located at the orbital apex, and it mainly supplies the sclera, ciliary body, iris, cornea, and the perilimbal conjunctiva, that is the conjunctiva around the corneoscleral junction. So, coming to the peripheral parts of the conjunctiva and the upper part of the eyelid skin supply, superiorly, it is supplied by the supraorbital and the supratrochlear nerve. Mainly, they are the branches of the frontal nerve. And medially, it is supplied by the infratrochlear, laterally by the lacrimal nerve, inferiorly by the infraorbital maxillary branch. So, these are the motor and the sensory nerve supply, which you should remember. This is a brief anatomy. Now coming to the techniques of needle blocks, mainly there are 2 types, retrobulbar, peribulbar. Retrobulbar is otherwise called as intraconal. Why? As you can appreciate in this picture, in retrobulbar, the local anesthetics are deposited behind the globe. Here we see that local anesthetics are aimed directly into the target area, that is the ciliary ganglion. And hence what happens? Minimum amount of local anesthetics is required. And quicker onset of action can occur with intraconal blocks. Coming to the peribulbar blocks, as you can appreciate in this picture, the local anesthetics is deposited outside the cone here. And the liquid all the way has to traverse from the extraconal space and into the intraconal space. So naturally, local anesthetics volume required will be more in extraconal, and there will be a slightly delay in onset of action. This is the basic difference between retrobulbar and peribulbar. Apart from this, there is a slight difference in the peribulbar and local retrobulbar with regard to the action on the nerves. This is because of the anatomical location of the nerves. This is the muscle cone. As you can see inside the muscle cone, the present nerves are nasociliary nerve, which is the main sensory nerve supply nerve, and the oculomotor nerve, which is the main motor nerve, as well as the abducens nerve. So these nerve gets blocked efficiently in the intraconal blocks, whereas these 3 nerves, that is the trochlear nerve, frontal, and lacrimal. Trochlear nerve is the one which supplies the 4th cranial nerve, SO4, superior oblique, frontal and lacrimal, which supplies the superior and the lateral parts of the peripheral conjunctiva, These may not be sometimes blocked in case of intraconal. They get spared. So this point you should remember, difference between the intraconal and the extraconal. Now coming to the technique, traditional retrobulbar block, it contains mainly 2 injections. First injection is given at the inferolateral quadrant, that is at the junction of the medial 2/3 and lateral 1/3 along the floor of the orbit. The needle used is 23 gauge 31 millimeter needle. 1 inch needle can be used. Once the needle is inserted here percutaneously at 10 degrees elevated from the transverse plane, the needle passes tangential to the globe past. Then once the needle tip has reached the equator of the globe, in retrobulbar, what we do? We turn the needle medially and upwards inside the cone, thus up till the needle hub junction has reached the plane of the iris. So we can see the needle tip is inside the muscle cone here. Now 2 minutes of digital ocular massage is done, mainly to enhance the spread of local anesthetics. At the end of 2 minutes, you should assess for echinacea. If incomplete echinacea is achieved, then supplementary injection is given at the supromedial quadrant. This is the traditional block just below the supromedial notch using the same needle. What are some of the advantages and disadvantages? Advantages, as I was mentioning before, it has a quicker onset, and since the local anesthetics volume required is less, there is less rise in intraocular pressure. But as you all know, the needle is inserted too deep and angulated medially. So what will happen? Naturally, there can occur orbital and systemic complications. And also, since most of the local anesthetics are deposited inside the cone, eyelid echinacea may not be achieved. So this is some of the major advantages and disadvantages. Now we will see briefly about the complications, mainly the orbital complications. Minor one is chemosis and subconjunctival hemorrhage, which resolves on its own, so no need to worry. Optic nerve damage, yes, it can happen, especially if the needle is inserted too deep, iatrogenic needle injury. Sometimes LA myotoxicity can occur, resulting in extraocular muscle malfunctioning. But 2 important orbital complications which I would like to focus upon today is orbital hemorrhage and globe damage. Remember, orbital hemorrhage can be a venous in type or arterial in type. Venous in type hemorrhage is slow in onset and markedly blood-stained chemosis can occur. It requires intermittent digital massage. Whereas if it is an arterial hemorrhage, sudden proptosis, tight eyelids immediately occurs, and there can be sometimes loss of vision, retina or disc can become pallor, dramatic increase in intraocular pressure can occur, which in turn requires firm digital massage, IV mannitol, sometimes acetazolamide is also required. Surgical intervention sometimes required is paracentesis, and to avoid compartmental leg syndrome, sometimes even emergency lateral canthotomy is also done. This is one of the picture I would like to share where we can appreciate the complete proptosis and the tight eyelids. Eyeball becomes really stony hard. Coming to the globe damage, you should remember 2 entities, namely perforation and penetration. What is the difference? I will tell you. Perforation is the one where there will be both entry and exit wound will be there. Whereas penetration, only the wound of entry will be there, exit will not be there. So what are the signs and symptoms? There can be sudden loss of vision, hypotonia, patient may complain of intense pain, absent or poor red reflex, which will be appreciated by the surgeons using indirect ophthalmoscopy. So immediate retinal surgeon intervention is required. If there is a mild vitreous hemorrhage, they just do a laser treatment. If it is a moderate vitreous hemorrhage, they do vitrectomy. If suppose there is a dense vitreous hemorrhage seen along with retinal detachment, they do vitrectomy, and tamponade effect is produced by injecting silicone oil. Coming to the systemic complications, local anesthetic systemic toxicity can occur, and central spread of local anesthetic agents and allergic reactions to adjuvants can happen. I think local anesthetic systemic toxicity has been previously completed in the same Pudukkottai branch Pudan. So I don't want to concentrate on this. Let me focus on these 2, the central spread of local anesthetic agent. What is the mechanism? Sometimes it is due to the retrograde arterial spread. That is, sometimes the needle is accidentally inserted into the arterial major ophthalmic vessels, then retrograde arterial spread can again lead to LA spread centrally. But the interesting part is direct injection of the local anesthetics into the dural cuff around the optic nerve. How this happens? Now, this is, as you all know, the optic nerve is in turn enclosed by a dural sheath along this optic nerve here, the optic tract to the midbrain. So, if during that block, if the needle tip pierces the optic nerve sheath, what will happen? The local anesthetics injected will then traverse along the optic nerve sheath, and then it can reaches the brain, and the most nearest part here is the midbrain. So that is how it reaches the midbrain. Now, one more interesting picture I want to share with you all. If the eye is in the primary gaze, this is the needle tip. Sorry, the picture is not very clear, but here is the needle tip. And as you can appreciate, the optic nerve is far away. But in case, if the eye is in Atkinson position, that is, the eyeball is turned upwards and away from the needle, what will happen? The optic nerve will be dragged towards the needle tip, that is at the inferolateral quadrant, and the tip will shear the optic nerve sheath. So, following which, if local anesthetics is injected, then they can spread easily and reaches the medulla, midbrain. One more important point I just wanted to highlight here. As you can appreciate in this picture, the local anesthetics not only traverses here, it goes towards the optic chiasma and reaches the contralateral optic nerve. So very important is the signs is the contralateral eye signs can be there. What are the signs and symptoms of brainstem anesthesia? Remember, typically it occurs 10 to 15 minutes following block. Patient may suddenly complain of drowsiness. Sometimes he may be disoriented, slurring of speech, agitation, sweating. Suddenly the patient may not respond to any commands, and there can be rise in blood pressure, difficulty in breathing. Sometimes even only intense shivering can be there. Temporary hemiplegia, dysphagia, tinnitus. It all depends upon the place where the local anesthetic goes and acts in the midbrain. The most important pathognomic sign is contralateral cranial nerve palsy, as I was mentioning in the previous slide. And coming to the allergic reaction, it is mostly due to the ester groups. It's sometimes due to the preservatives present in the amide types, mainly due to the methyl paraben. Amide types of local anesthetics can also result in allergic reaction. But in ophthalmic anesthesia, of late, remember, it is mainly the adjuvants used, that is the injection hyaluronidase, which is the main culprit that causes the hypersensitivity reaction. As you can appreciate in this picture, this gentleman has undergone uneventful surgery in this left eye, but you can appreciate the right eye is completely swollen and the whole face is completely swollen. Even the earlobe swelling can be appreciated. This is because of a typical hypersensitivity reaction to the injection hyaluronidase that is confirmed with the intradermal test given by us following. You can appreciate the wheel and the induration here. Now coming to the traditional peribulbar block, the first injection is given similarly at the inferolateral quadrant. The junction remains the same, medial 2/3 and the lateral 1/3. 23G 21 millimeter needle is used. The needle is entered percutaneously and the needle is passed below the globe, parallel to the orbital floor. But unlike retrobulbar, here the needle is not turned upwards or inwards. It is just kept parallel to the orbital floor until the needle tip has reached the equator, and then it is injected. Then again 2 minutes compression has to be given. If inadequate echinacea is achieved, then supplementary injection at the superomedial quadrant can be given. Coming to the advantages and disadvantages. Advantages, as you all know, the needle tip is outside the muscle cone. So naturally, what will happen? Orbital and systemic complications are reduced. Another interesting point is that since the local anesthetics is deposited outside the cone, some of the local anesthetics, they traverse through the facial veins and reaches the eyelid, and echinacea of the eyelid occurs in peribulbar block sometimes. But disadvantage, as I was mentioning before, there can be a little bit later onset, and since more local anesthetics is required, there can be a rise in intraocular pressure. But traditional percutaneous entry, is it safe? Currently, if you see, they are not safe and no more recommended. Why? The reason is at the junction of medial 2/3 and lateral 1/3, as we can appreciate in this picture, lies the structure, inferior rectus muscle and vessels supplying inferior oblique muscle. And there are a lot of literature, journal case reports which clearly shows that diplopia can occur if this traditional point is entered. And similarly, injection at the superomedial is not more recommended. The reason, it is the most vascular quadrant, orbital hemorrhages can occur, and it is the least space available there. So globe damages can occur easily at this superomedial quadrant. So what is the correct or the safe place in the modern peribulbar block? Here, this first injection given at the inferolateral quadrant is at the extreme inferolateral corner, that is still laterally from the traditional point, that is palpating the floor and the lateral wall, just above its junction you should give. And following 2 minutes digital massage, if inadequate echinacea is still there, then you should go for medial peribulbar block, not for the superomedial block. What is this medial peribulbar block? It is given with a 26 gauge half-inch needle passed in a blind pit between the caruncle and the medial canthal angle, and the needle is passed to a depth of 15 to 20 millimeter. Let me share a small interesting video. So before undergoing any blocks, it is important to thoroughly examine the patient, explain clearly to the patient what you are going to do. IV line must be started. Patient must be connected to monitor. This is the 23 gauge 1-inch steel needle. Identify the site of the eye, palpate the globes before giving the blocks, and then look for any abnormal gaze. If present, document it. Palpate the lateral wall, floor, just above the junction with the bevel facing the globe. You insert the needle up to the needle hub junction. See, I'm not angulating the needle. I have kept parallel to the orbital floor, aspirating it and slowly injecting. You can appreciate in this picture that the upper eyelid starts to droop down, which clearly shows that I am in the right plane. Then withdraw the needle along the line of insertion. Give a digital massage for 2 minutes. Assess the block. See, the eyelid block has almost come. Little bit movements are there medially and superiorly, which can be settled easily with the medial peribulbar block. This is the 26 gauge half-inch needle. This is the caruncle and the 2 canthal angle. Drop the needle perpendicularly and aspirate and give the remaining 3 to 5 ml of local anesthetic solution. Again, digital massage can be done. 2 minutes. Assess the block. Complete eyelid echinacea and in total echinacea is achieved now here. Okay. Now coming to the last block, that is the subtenons block. This is otherwise called as cannula block, because unlike the first one where the needle is used, here we use a cannula, a blunt cannula, where it is introduced into the subtenon space, which is nothing but a virtual space around the eyeball between the sclera and the tenon's capsule. Tenon's capsule is nothing but a facial sheath that surrounds the eyeball and separates it from the orbital fat. Anteriorly, this tenon's capsule merges with the conjunctiva just behind the limbus. Posteriorly, it fuses with the meninges around the optic nerve. Now, following surface anesthesia, that is, you should instill proparacaine drops. Then at the inferonasal quadrant. Why at this quadrant? This is because it is the least vascular and this quadrant is not preferred by the surgeon. So at the inferonasal quadrant, 3 to 5 millimeter away from the limbus, the fused conjunctiva and tenon's capsules are gripped with the non-toothed forceps. Then using a viscot scissors, a small nick is made into the conjunctiva and tenon's capsule until a white sclera is exposed. Then the closed scissors is then introduced to create a thin channel just past the equator of the globe to the posterior subtenon space. Remember, the scissor should not be opened, and the scissor with the closed position, it is then withdrawn. Then conjunctiva and the tenon's layer is continuously held and then a blunt curved posterior subtenon cannula 19G 25 millimeter long curved one mounted to a 5 ml syringe is then inserted through the hole along the curvature of the sclera. Once a depth of around 15 to 20 millimeter is achieved, 3 to 4 ml of local anesthetics injected into the subtenon space. What is the mechanism of action? Once the local anesthetics is injected into the subtenon space, they directly act on the short ciliary nerves that traverse the subtenon space. Also, they spread along the muscle sheath and diffuses into the intracameral compartment. Moreover, the local anesthetics also spreads forwards into the facial space around the eyelids, and sometimes even eyelid blocks also can occur. Advantages: lesser pain when compared to needle blocks, lesser complications, decrease in IOP and eyelid echinacea can occur. But remember, it is not so suited for repeat surgeries. The reason is conjunctival scarring can be there. So you should be more careful. And sometimes a variable degree of echinacea can be achieved. Lastly, I thought I will also cover this facial nerve block. Sometimes it can be asked as a short notes. So I just finished with this facial nerve blocks. Facial nerve blocks are of 4 types. It is mainly depends upon the location at which the facial nerve is blocked. It can be blocked either at the proximal trunk or at the periphery. Now, at the proximal trunk, there are 2 types, namely O'Brien and Nutbath. O'Brien is nothing but injection of the local anesthetics anterior to the tragus, just above the mandibular condyloid process. Modified O'Brien is Nutbath. Here, injection inferior to the earlobe. These are all the proximal trunk branches. Now, if the facial nerve is blocked in the middle, then it is called Atkinson. That is, in here the injection is made along the inferior edge of the zygoma. See here, you can appreciate inferior edge of the zygomatic bone, and then upwards across the zygomatic arch towards the top of the ear. Peripheral branches of the facial nerve is Van Lint, infiltration just above the eyebrow and below the inferior orbital margin. But practically speaking, facial nerve blocks are no more practiced commonly. Reason is it is quite painful and complications can also occur. So we just obtain the upper eyelid and lower eyelid blocks by just skin infiltration using 26 gauge half-inch needle. With this, I just want to share with you a few information. Those people who want to practice ophthalmic anesthesia in future and who wants to know more can read about our book called Principles and Practice of Ophthalmic Anesthesia that is available on Amazon. And still more, those who are interested, please do join and visit us this website and they can become a member of it. We have an Indian Journal of Ophthalmic Anesthesia that is brought once in 6 months. And there is an upcoming conference in Aravind Eye Hospital where we are going to have a live demonstration of blocks, workshop, interesting lecture. Please do join with us. Thank you all.
Thank you, Dr. Jayachandran. Very elaborately, you described the classical textbook blocks, which are very, very important for the postgraduate students to learn because that can come as an examination. And we surely will have some discussion on this if the time permits. But before that, I would like to invite Dr. Renu Sinha from All India Institute of Medical Science, Delhi, to start her presentation. And before she shares the screen, let me tell you, Dr. Anusha, I felt you have a very professional approach to talking, giving a talk. You exactly took 10 minutes, which you were assigned. And thanks to the mentorship of Dr. Pratibha, and you are an inbound speaker now. So please keep it up. And Dr. Renu.
Yeah, thank you, Dr. Ashish. And now I will start sharing my screen. So today's topic is anesthesia for squint surgery. So we should all know that the 50% of the ophthalmic surgeries include squint. So if we are practicing pediatric anesthesia or ophthalmic anesthesia, we will tend to get many more patients of squint surgery rather than other surgeries. So what is squint? It is an ocular misalignment that is leading to loss of binocular vision and amblyopia. The incidence is 2 to 7% in children. Usually by 3 months of the age, the neonatal misalignment resolves. But the surgeon usually wait till 6 months before proceeding for the squint surgery. So mainly the patients which we get is 1 to 4 year of age, and the surgery before 5 year is giving a good result because of the completion of visual maturation after that. So what is done in squint surgery? There is reposition of insertion point of extraocular muscles to restore the alignment of the eye. And the surgeries which are usually done is resection, and transposition. For this, in the pediatric patient, it is very difficult to know what type of muscles are having problems. So after anesthesia, there is one test which is done, which is forced duction test. In this, after general anesthesia, the surgeon tests the range of the motion of the extraocular muscles to distinguish between paralytic and mechanical restriction of the muscle. So the goal of surgery is to avoid amblyopia, to improve stereopsis, that is depth perception, to eliminate diplopia, and to provide orthotropia, means cosmetic correction. So as an anesthetist, what are the concerns when we have a pediatric patient for squint surgery? So in ophthalmic surgery, especially in squint surgery, we have 4 concerns. First is occurrence of oculocardiac reflex, intraop and postoperative pain, and squint surgery per se, the more incidence of postoperative nausea, vomiting, and chances of malignant hyperthermia and masseter spasm. We will deal one by one. So once we are getting a patient which is listed in the OT list for squint surgeries, how to proceed? First of all, pre-anesthetic checkup is very important. So pediatric patients have lots of problems, and the squint surgery patients will also have congenital heart disease, maybe neurological deficit, attention deficit disorder, cerebral palsy, they may be obese, they may have craniofacial syndromes. All ophthalmic patients who require ophthalmic surgery may have these. So in squint per se, the chances of patients having cerebral palsy are more. There are some syndromes, just like a Cruzon syndrome. These patients have squint because of the misalignment of the eye. They may have myopathy, mental retardation, developmental delay, and seizure disorder. Seizure disorder are mainly seen in squint patients who are having squint. So because of these diseases, the family history is very important. Many times they are preterm children. So NICU stay and other records are also very important in the pre-anesthetic checkup. So once again, the pediatric patients problems just such as congenital anomaly, congenital heart disease. So we will see the cyanosis, limited physical activity, whether they are having sweating during feed. In this age group, we will get enlarged tonsil or adenoid. So maybe patients are having obstructive sleep apnea, snoring. We should check the IV axis in the preoperative checkup, and airway. Many of the children who are having syndromes or cerebral palsy or other mental retardation, they have difficult airway. In the previous anesthesia record, we should see the medications, because if the patient is having cerebral palsy or seizure disorder, they will be on some medication. We should chart them. We should also see the risk for PONV, such as history of motion sickness, which increases the risk of postoperative nausea, vomiting. If the postoperative nausea, vomiting is there in the previous surgery, they will be having more chance of PONV. Emergence, delirium, allergy. So in the preoperative order, we will ask to continue medications till the day of the surgery, because usually we keep them, they are on the oral medication. We can give with the sips of water if the age allows. Give NPO orders, informed written consent. For high-risk patients, pediatric HDU can be arranged. And if we want to have IV beforehand, then AMLA application to be listed. So for squint surgery per se, anesthesia goals are smooth induction and emergence, avoidance of oculocardiac reflex, control of ETCO2, prophylaxis and treatment of postoperative nausea, vomiting, and adequate perioperative analgesia. So we will start with anesthesia management after the pre-anesthetic checkup. So In many patients, we give pre-medication. In many patients, we don't give, but ideally pre-medication should be given, and various forms of pre-medications are available. Midazolam, ketamine, dexmedetomidine. Midazolam can be given oral, nasal, or intravenous, and it has been seen that giving the midazolam will decrease the incidence of OCR and post-operative nausea, vomiting. So in the exam, you will say, yes, I will give midazolam, whatever preparation you have. Ketamine is also decreasing the OCR and PONV, and particularly for the dexmedetomidine, it can be given oral, intravenous, or intranasal. It has been seen that it decreases the intraoperative and post-operative pain. It decreases the emergence delirium, but in squint surgery, one should keep in mind, because it decreases the heart rate, so chances of bradycardia will be more. Clonidine is also given, and anticholinergics. Initially, it was said that atropine or glycopyrrolate, if it is given, that it decreases the oculocardiac reflex. But nowadays, we don't prefer to give anticholinergics as a pre-medication. And in anesthesia technique, induction, many times induction depends upon whether the patient is having previously IV cannula or not, or whether patient prefers IV cannula before induction or not. So it can be inhalational if the child is saying that he doesn't want to have IV cannula, or it is an anesthetist choice also. So you will be able to justify both inhalational and intravenous in the exam. So in inhalational, usually halothane is not available in a center, but if it is available, then sevoflurane and halothane, both can be, any of them can be taken. And for intravenous, propofol or thiopentone, both can be given as a choice. For maintenance, inhalational anesthesia maintenance can be done with sevoflurane or isoflurane, or if your patient is obese, then you can also say the desflurane. In many centers, Tiva is used with propofol and remifentanil. We don't have in India remifentanil, so you can say propofol along with the fentanyl boluses you can give. In many places where they are doing the squint surgery in camps, they are using propofol as an infusion for the anesthesia, because they are not having machines. So you can justify both. Inhalational and Tiva both have some or other problems. So if somebody will ask why Tiva, then you can say the incidence of post-operative nausea, vomiting is less with Tiva, although incidence of bradycardia is more with Tiva in squint surgery. And the opposite is with the inhalational agent. In inhalational agent, incidence of bradycardia is less, but incidence of post-operative nausea, vomiting is more. For analgesia, because squint has more pain, so opioid is used at many places, but using of opioid will increase the post-operative nausea, vomiting. We usually use fentanyl in our place. So the next is NSAIDs. In some centers, they say that opioid should not be used and you can manage with paracetamol and ketorolac. So it will depend upon the protocol of that institute. So you can say that opioid can be given, and if need, an NSAID along with that. Topical anesthesia is usually given by the surgeon during the surgery in the form of proparacaine. In the West, it is amitocaine, and we can give lignocaine drops or lignocaine gel also. Then regional blocks are recommended in cases where the surgeon is also comfortable. So in exam, you can say that peribulbar block can be given, and subtenon block intraoperatively can be given, because anyway during the squint surgery, the Tenon's space is open. So at that time, the surgeon can give subtenon block, because they provide good analgesia. It decreases the incidence of OCR, and because the opioid requirement is less, so you can say that less PONV is there with regional blocks. Then comes the muscle relaxant, whether you need muscle relaxant for squint surgery or not. So it is not needed in the squint surgery, but many places we also use in few patients non-depolarizing muscle relaxant. If you are using muscle relaxant, non-depolarizing muscle relaxants are preferred. Succinylcholine, because in these patients, the chances of masseter spasm and malignant hypothermia is seen. So succinylcholine should be avoided until and unless you are, this patient is not myopathy, then you can use. But succinylcholine has one more concern, because in pediatric patients, forced duction test is done. And if you are giving succinylcholine at the time of induction and before intubation, then it can cause prolonged depolarization and muscle contraction, which can last up to 20 minutes. So it will result in false positive FDT, which is not required. So if any case you are giving succinylcholine, you should tell the surgeon that I had given the succinylcholine. So he can do the force duction test little bit late. Ventilation. The aim of ventilation is to provide normocarbia. So it can be provided with controlled ventilation or spontaneous ventilation. So because in many places the muscle relaxant is not given, so it can be kept in spontaneous ventilation. But now the newer machines have pressure support ventilation. So if you are not using muscle relaxant, then you can keep the patient on with pressure support ventilation, because you have to maintain the normocarbia. And watch for oculo-respiratory reflex with spontaneous ventilation. I will come a little bit later on oculo-respiratory reflex. Then airway device. Which airway device you will choose? It is supraglottic airway device or endotracheal tube. So both have advantage and disadvantage. With supraglottic device, the advantage is there is less airway stimulation, smooth removal, and it can be used as a conduit for difficult airway, which happens to be there in squint surgery also. Concerns are, if there is difficult airway, chances of displacement is there intraoperatively and in squint, and in ophthalmic surgery, airway is always away from you. Once we are putting endotracheal tube, we can also justify endotracheal tube, as this is a definitive airway, the chances of displacement is less. And if you require ventilation with high airway pressure, you can do with endotracheal tube, then supraglottic device. The disadvantage is because it causes airway stimulation, it can cause coughing and bucking during extubation. And for endotracheal intubation, you require muscle relaxant. Then coming to the most oculocardiac reflex. By definition, oculocardiac reflex is 20% decrease in the heart rate from the baseline. Sorry. The incidence is 14 to 90% in squint surgery. And if the muscle is pulled severely or quick, then there will be abrupt or sustained traction of extraocular muscle, then oculocardiac reflex occur very suddenly. And you should also know that it disappears on discontinuation of stimulus. And many times, if you do it repeatedly, then there is OCR fatigue, and then you will not have oculocardiac reflex. Then for oculocardiac reflex, during the traction of extraocular muscle in strabismus surgery and VR surgery both, there is stimulation of the stimulus goes to the ophthalmic division of trigeminal nerve, and from that to the ciliary ganglion, Gasserian ganglion, and the efferent is through brainstem to the vagus nerve. And then there will be, it can occur bradycardia, bigeminy, ectopic, nodal rhythm, AV block, and complete asystole can also occur. So one should keep in mind during the squint surgery that you should keep the volume of your heart rate little bit higher. So if you are there on the side making drugs, you should listen it. Then factors which will affect the oculocardiac reflex. There is increase in oculocardiac reflex if there is light anesthesia, there is hypercarbia, hypoxia, sudden traction on extraocular muscle, and if halothane is used. In the inhalational anesthesia, halothane causes more bradycardia than sevoflurane. And if we'll compare with opioid and inhalational, then opioid causes more bradycardia. And the chances are less once anticholinergic is given, which is now not recommended, midazolam or ketamine. There is no effect of sevoflurane, desflurane. And if you maintain the normocarbia, then there is no effect of ventilation on the OCR. How to prevent it? You should communicate with the surgeon that he should tell you before manipulation of the muscle, but you should also be very vigilant. There should be gentle manipulation of extraocular muscle. The depth should be adequate, and you can apply BIS monitor. Hypoxia and hypercarbia should be avoided. And as I told, that anticholinergics are now not recommended prophylactically. The treatment of OCR is, as soon as there is bradycardia, you inform the surgeon. Otherwise, the surgeons who are the experienced one, they also listen the volume of the heartbeat. And as soon as there is bradycardia, they usually release the stimulus. There is fatigue with repeated stimuli, that we should ensure the adequate depth. if there is hypoxia or hypercarbia, it should be treated. Repeated installation of proparacaine can be done, and preoperatively, pre-surgery regional blocks can be given, and one report is there in which intratrochlear nerve block is also given. But still, if there is oculocardiac reflex, then 5 to 10 mg per kg atropine can be given to relieve the OCR. There is another reflex, oculorespiratory reflex, which is basically seen once the patient is on spontaneous ventilation. So the triggers are same as oculocardiac reflex. Afferent pathway is same, but the efferent pathway is directed towards respiratory control of brain system, which goes to the phrenic nerve and other respiratory nerve. The result is decrease in the tidal volume and respiratory rate. Both will increase the EtCO2 and can cause hypoxemia, which can cause increase in OCR incidence. So if the patient is on spontaneous ventilation, one should see the decrease in tidal volume or respiratory rate and should put on pressure support ventilation. Then the second thing is post-operative nausea, vomiting. In children, many times they don't tell you about the nausea, so it can be called as post-operative vomiting. The incidence is 9.4 to 42%, and without prophylaxis, it has been seen that it is 35 to 90%. It can cause dehydration and electrolyte imbalance. During the vomiting, there will be retching. So subconj hemorrhage can occur, and the loosening of surgical sutures can occur. There is delayed discharge, unplanned admission. Along with that, decreased satisfaction of the patient attendant and increased use of resources because of the admission. So what should be done to relieve the PONV? We should know that the risk factor of PONV is if the duration of surgery is more than 30 minutes. That means the patients who are for more than 2 muscles, they will have anesthesia for more than 30 minutes. If there is past history, if the child is female, if the opioid is given, if during the initial mask ventilation, there is gastric distension, if post-operatively there is forced oral intake and early ambulation. So factors which will increase the post-operative nausea, vomiting are also the patients who have centrally mediated oculomimetic reflex is there due to extraocular muscle manipulation. Post-operatively, there is alteration in visual perception, which lead to diplopia and increase in post-operative nausea, vomiting. As I told that if the more number of muscles are operated, then more time is taken during the surgery and anesthesia, and it will increase the risk. Then surgical technique. If there is posterior fixation of the muscle or more sustained stimulation during the surgery, then post-operative nausea, vomiting will be more. So we should treat that. How to prevent the post-operative nausea, vomiting? There are many studies. So in the exam also, you can say to prevent it, we can give the pre-medication. It has been said that hydration should be adequate. There should be no forced oral intake in the post-operative period. And some studies says that increase in FiO2 can reduce the post-operative nausea, vomiting, or avoidance of nitrous oxide can lead to decrease in the PONV, and acupressure at P6 level spot. So if you are doing very well in your exam, then the examiner can ask you about the other recent thing. So as I told that with the inhalational anesthesia, there is low incidence of PONV. If you give intravenous paracetamol, chances of pain will be less, then incidence of PONV will be less in first 24 hours. If you give good hydration, that means 30 ml per kg per hour, then the chances of PONV will be less. And another study, if somebody asks about the increase in FiO2, then it has been seen that increasing the FiO2 more than 0.5 in this study, there was 0.8, there is no benefit of a decrease in PONV. So we know so many things about the PONV. So how to give prophylaxis and treatment of post-operative nausea, vomiting? The drugs are the main goal, stay for the treatment of and prophylaxis of PONV. So in the squint surgery, usually the single and 2 drug therapy is given. So dexamethasone can be given, clonidine can be given, but usually we give dexamethasone and 5-HT3 antagonist. And for the rescue, we give metoclopramide. So dexamethasone is given 150 mg per kg after the induction, and ondansetron 0.1 milligram per kg. If the patient is having post-operative nausea, vomiting, the previous surgery also, you can use granisetron, which has good more than prophylaxis is good than ondansetron. And for the rescue in the post-operative unit, you can use metoclopramide, 150 mg per kg. So it has been seen that the combination of dexamethasone and antiemetic such as ondansetron markedly decrease the incidence of post-operative nausea, vomiting. Then coming to the regional and blocks and PONV. As I told initially also that the incidence of PONV is reduced if you use regional blocks, subtenon, peribulbar or topical. But lately it also depends on the surgeon, because once they are giving subtenon block, they say that the muscle is a little bit more boggy and their precision for doing the surgery is not that good. So mostly in our place, the squint surgeon, they give the subtenon block after the surgery is, after the cutting resection is done. Before closing, they are giving. So for the surgery per se, you should give opioid or paracetamol to reduce the pain. It has been said that if you compare the incidence of PONV, then it is maximum with propofol and meperidine, propofol with fentanyl. But once you are using propofol with peribulbar block, or you can use with subtenon block, the incidence is less because you are not using the opioid and the OCR is less. And occurrence of OCR is also a factor for increase in the post-operative nausea, vomiting. As I told you that post-operative pain is more in squint surgery, and you can see that 50% of cases of squint surgery are there. But if you see the post-operative pain after the ophthalmic surgery, it has more than 70% of patients who have post-operative pain after the squint surgery in comparison to other surgeries. So intraoperatively, we have used either the regional block or topical along with paracetamol and ketorolac. In the post-operative, in the PSU, the choice is yours. You can say that you can use fentanyl in the post-operative care unit. NSAIDs can be given in the form of acetaminophen, ibuprofen in the ward, ketorolac if it is not given intraoperatively, and in some places diclofenac if ketorolac is not available. So after the surgery, the extubation should be smooth. There should be no coughing and bucking. So if the supraglottic device is inserted, you can remove it at the MAC of 0.3 if the airway is not difficult. At some places, they say that stomach suction should be done to avoid any remaining gas in the stomach, but we usually don't do, and put the patient in the lateral position on the side where the surgery is not done. But in squint surgery, usually it is bilateral. So you should try not to compress the eyeball once you are doing the patient in the lateral position. In the PSU, eye patch is there in one eye or both eye. It is also at your institute what is done, because at that time you can say more confidently that we do this. In our place, we put the eye patch in both the eyes during the extubation, but in the recovery, we remove one eye patch so that the child is less anxious. In the PSU, watch for post-operative nausea, vomiting, and if it is dexamethasone and ondansetron is given in the OT, and if still the patient is having vomiting more than 2, then metoclopramide can be given. For pain, as I told you, that you can give fentanyl in the PSU and you can give the NSAIDs. Watch for emergence agitation. Many times you, after removing the one eye patch, they are a little bit less anxious and less crying. And if it is there, then you can use midazolam according to the weight of the patient to reduce the emergence agitation. So squint surgery is like other surgeries, other ophthalmic surgery, and you should see about the comorbidities, risk factor for PONV during the PSC. You should choose, usually we use supraglottic airway device, but you can justify yourself with endotracheal tube also. The OCR should be controlled and ETCO2 should be normal. PONV prophylaxis is given and should be given in the squint surgeries. And if the patient is having some other problems, then regional blocks should be preferred, but it should be comfortable with the surgeon also. Opioid use, we use it, but if you want to avoid it, you can avoid it by giving regional block and PCM. And treatment for post-operative pain, PONV, and emergence delirium should be done in the recovery. So, thank you very much. Now over to Dr. Ashish.
Thank you, Dr. Renu. Thank you so much. Very nicely narrated the whole concept of squint management and covered a lot of things elaborately about the oculocardiac reflex. You can stop sharing your presentation.
Yeah, sir.
And I'll request other people, the participants, please share your questions in the chat box so that we can cover the questions. And Dr. Meenakshi Sundaram, how much time we have now? It's about 7:25 now. Most important is the understanding of the anatomy. The orientation of applied anatomy is very important for the regional blocks. And if you look at our human face, you can understand that there is so much anatomical architectural variation in the orbit and the eyeballs. There are large orbits, small orbits, shell orbits, long eyeballs, short eyeballs, huge eyeballs. So because of this variation in the anatomy of orbital structures, it is very, very important that you have an orientation of applied anatomy of orbital structures. Because some of the complications like perforation and Dr. Jayachandran described very well the central spread of the drug, the incidence is very low, but the magnitude of the problem is very deadened. It could be life-threatening, or it could be eye-threatening or vision-threatening. So this is very important that you understand the anatomy. Very important point he raised was that there should be IV line and monitors for every patient. Third point is particularly for the perforation, you must have the idea of axial length of the eyeball before actually you put the needle in the orbit. So look for, is there a myopic patient? Is there a very long eyeball where it's more chances? And the myopic patients may have a thin sclera or sometimes have the staphyloma, which could be an abnormal shape of the eyeball, which your B scan or the ultrasound, the ophthalmologist usually do beforehand will tell you. So you need to check as a pre-anesthetic checkup before giving the blocks about the axial length and the scans of the eyeball. Now there are a couple of questions. I'll cover first two questions in the chat box. One, Dr. Jay, for you. Both these questions are asked by the same person. Can we use ultrasound block for the regional blocks in ophthalmology?
I think it's a mere coincidence. Myself and Dr. Renu has wrote an interesting article in this Indian Journal of Ophthalmic Anesthesia. Ultrasound guided, yes, but it is still in the infancy stage only, because the main reason is that USG transducer, it has two index, namely the mechanical index and thermal index. Mechanical index is the one they say which causes that cavitation and tissue stress. Thermal index is the one which they say that raises the thermal tissues. These two are not so that user friendly to when compared to the other transducers, but of late there are some new transducers have come out. But the main disadvantage is that here it is time consuming. Number one, it requires two people, and the other thing is it has to be done in two stages. First is the needle has to be injected, then eye has to be closed, transducer has to be kept. Remember, the transducer should not be kept for more than say about 60 to 90 seconds. Still it can cause thermal damage. So somehow, no, performing injection with the closed eyelids, I don't know how many of them will be comfortable with this, because to my knowledge, while you are injecting, you should be completely viewing the entire conjunctiva so that any hemorrhages happens, we'll come to know. But still, very rarely it can be used, especially if there is a staphyloma, still we can use it. But especially in Indian scenario where there is high ophthalmic turnover, I think still it is a long way to go.
True, Jai. Actually, I have tried with the B-scan, particularly for high marks, but it is not a very user-friendly technique. So, and to take it to the operation theater, it was a little difficult, so I couldn't do it. This second question is for Dr. Renu about the force reduction test. If you are paralyzed with the non-depolarizing muscle relaxant, can the ophthalmologist perform the test?
Yeah, they can perform.
So,
Because
do you recommend?
Yeah, because fibrotic muscles, they don't relax.
Yes.
Flexed muscles are anyway flexed, but fibrotic muscles, they are fibrosis. So they just do the force reduction test for, I think in our place, for 10 seconds just to see the muscle. Only. So yes, we give. I usually prefer non-depolarizing muscle relaxation for surgery.
Yeah, technically true. Because we don't, these days we don't use hexametronome anyway for the induction. So it is best is to use the non-depolarizing muscle relaxant. It works well. Hexametronome chloride is a little
we
problem.
use non-depolarizing muscle relaxant with the supraglottic device, but the dose is less.
Right. There is a question for you. Can we use ketamine and mizolam for and block the squint? I don't understand. Can you elaborate the question, Dr. Dipti?
Yes, sir. Can we give?
You mean? Yeah. Repeat question.
Can we give, sir, ketamine and mizolam IV, and with that peripheral block for squint surgery?
Dr. Deepti, are you asking for pediatric patients or for adult patients? Because in pediatric patients,
No, madam, for pediatric patients.
So for pediatric patients, I don't recommend, and I will not do midazolam and ketamine and peribulbar block for the surgery because why you want to do this midazolam, ketamine and peribulbar block for surgery? There is any specific need, or you don't have general anesthesia machine, or you want to avoid general anesthesia? So usually in our place, we don't do it like this. Maybe if you are doing, you can do it, but ketamine usually causes the nystagmus, but with peribulbar block, the nystagmus will not be there. Are you doing it in your place?
Yes, madam, we are doing it in our place. And so many patients I have given this type of anesthesia, they all are fine. So I am asking, is it possible? Is it right way to do?
Strictly speaking, it is not a right way because maintaining the airway is always the gold standard. So under the drapes, if the surgeon is taking, suppose if there is a muscle exploration taking, sometimes if it is prolonged, then I think in one way or the other, you will land up in trouble only. So ideally speaking, supraglottic airway device or endotracheal intubation is the gold standard for squint surgery.
Okay, sir.
Yes, I agree, Dr. Dipti. It's not a standard copybook technique, which when we talk to the postgraduate students, we should be describing. But many times for the reason of the little compromised infrastructure, or it becomes a clinical practice, we use it. But when we talk to the postgraduate students, we always talk about the standard technique, and probably this is not the standard technique for squint surgery. And there are more questions coming up. The same thing for ketamine. Somebody has asked eye movements with ketamine anesthesia in squint surgery. If you're not paralyzed, yes, you do get nystagmus sometimes. Please write your questions. Ultrasound, yeah. Can we have ultrasound in IOP measurement? Well, you want to answer, Jai? Or Anusha, you want to answer? Ultrasound, can we have ultrasound in IOP measurement? I don't understand why we need ultrasound.
IOP measurement is not ultrasound based thing.
Yeah.
It's either non-contact or, I mean, applanation and non-contact. And even in, so I think.
Yeah.
Sir, there is ultrasound role is there. in IOP measurement depending on the waves transmission, sir.
That is B scan and A scan.
Yes, yes.
Which one is he is asking, because that is mainly
I am
done by
doctor.
the ophthalmologist.
Virasham is asking
Yeah.
about that. And B scan and A scan are the routine pre-operative examination by the surgeons. So they use it, but I have not seen our place, even in the glaucoma unit, they depend on this for the particularly diagnosing glaucoma or measuring the intraocular pressure.
I meant to say it may be one more gadget in measuring the IOP.
Yeah, but I agree with you, Dr. Virashan. But there's less relevance to the anesthesiology fraternity for this, because it is a purely diagnostic technology for the ophthalmologist to use. Well, let us discuss more on the questions related to anesthesia and management. One more question, Dr. Jai, for you. You talked about regional anesthesia very well, but you have an adult patient with penetrating injury. Would you recommend, and when will you not, the regional technique?
So actually, there are some interesting paper presented by Stephen from US, where regional anesthesia plays a role in open globe injuries, especially if it is very minimal one. Suppose if it is around, say, the posterior part of the wound is seen and 3 to 4 millimeters from the limbus and not much of uveal iris prolapse is occurring, there is a technique of block called as combined retroperibalbar technique. It has also been published in an indexed journal. That is, first they give retrobulbar 2 to 3 cc. With this, what will happen? The entire sensory nerves get blocked. But one of the disadvantages with this is that eyelid echinacea will not be established. So what they do is they come to the extracorneal space, and then with the same needle, they deposit the local anesthetics in the peribulbar. It is called as a combined retroperibalbar technique for open globe injuries. For certain open globes, yes, it has a role, especially if GA is absolutely contraindicated. I myself has tried this in certain COPD cases and find useful.
Very true. And actually, I tell you, what I practice sometimes, like with comorbid patients like COPD and all, where you are really worried about, and this is always an emergency. So instead of that, I used to give, very rarely I have given the facial nerve blockage for these cases. And that too, O'Brien's technique, not even from lint, not away from the eyeball. It's a very painful technique, more than the peripheral. But this is, and facial nerve block is taught very well. It's a rescue block. It's a rescue block in a long surgeries, particularly vitreoretinal surgeries, which it takes long. Because in a peribulbar, the facial component, the lead echinacea is a byproduct. And usually it wears off fastest. So if the surgery lasts 2.5 to 3 hours, sometimes you do the Fondlin block as a rescue block. And normally I've seen the surgeons themselves giving it when the patient starts blinking. And that is a rescue block. Renu, the same question for you. You have a 4-year-old child with a penetrating injury.
Yeah.
What will be your what will be the difference in the general surgery? Do you have any special point you want to raise?
Yeah, as the first,
because sometimes this penetrating injury
IOP.
full question comes for postgraduates.
Yeah. So for penetrating injury, as the first speaker told, that IOP. So all the things should be done to not to increase the intraocular pressure, such as face mask application, and then you can. General anesthesia is given. IV induction is usually done in these kids, and we use supraglottic device and muscle relaxant also. But about the, just like all other surgeries, just you should avoid hypoxia, hypercarbia. There should be no increase in intraocular pressure. And supraglottic device is very useful because there is less coughing and bucking at the time of extubation and at the time of insertion also. And it has been more problematic if the patient is full stomach and they want to do surgery urgently. So at that time, it should be discussed with the surgeon that whether the patient can wait for 4 to 6 hours. And if yes, then it's very good. Otherwise, supraglottic device with gastric channel is usually used, and along with antiemetic and analgesics, just like fentanyl and paracetamol.
Right.
Yeah.
I'll come back to you. But before that, there's a comment on we can measure the ICP.
Yeah.
by
with
measuring optic
Yeah,
nerve
it
sheath.
can be done, sir.
Yeah.
It can be
Fine.
done.
It is
Yeah.
done. It is
Yeah.
nowadays.
Yeah.
There are studies also.
Yeah, it is a routinely done in our place. But let me tell you one more thing we do in our place for last 10, 12 years is monitoring intraocular pressure during surgery. We put a paracentesis line in the anterior chamber, and it is connected to the transducers, the same which we use for the intraocular, intra-arterial blood pressure monitoring. And we have a software made to measure so that in difficult cases during surgery, they monitor the intraocular pressure also. And we have published papers also on this, special device. But we have used the same transducer which we use, the dome which we use for intra-arterial central venous pressure monitoring. It's a unique thing. I published this in the United States also last year. How about using supraglottic device for every pediatric case? Do you recommend?
Yeah, we are very comfortable using in even at 2.5 kg kid.
1 month, 2 months, 1.5 months, baby also you do with the supraglottic device. So that's a good thing.
But it is
and
an
I saw in
So-
Madurai, is anybody from Madurai here? Arvind Eye Hospital? They have made a routine of using, I was very happy to see that they do most pediatric patients with the supraglottic devices under general anesthesia. You have a patient maybe under regional anesthesia or under general anesthesia, and surgeon complains of rising intraocular pressure. Anusha, would you like to answer this? How will you manage a rise in
Can you
intraocular?
repeat the question? I couldn't
There
hear.
is a rise in intraocular pressure during surgery. Surgeon says there is a posterior bulge. Please help me out to reduce the intraocular pressure. So, what things you will look for and how will you manage? If you are comfortable, answer it. Otherwise, these people will answer it. Don't worry. I'll be very happy. I'll be very happy to if you answer the question. Otherwise, don't worry.
We can start IV mannitol for the patients to reduce intraocular pressure. Posterior bulge may be due to hemorrhage during the surgery. So
There is no
it may be
hemorrhage,
one of the
but
cause.
sometimes that happens when there is a lot of vitreous bulge in some shallow anterior chamber surgeries, and surgeon is working on the posterior capsule, difficult cataract and small pupil. Sometimes with the narrow anterior chamber, we have to help them out sometimes. So you have already narrated few things in your lecture.
As I said, we can start IV mannitol or acetazole.
Wonderful.
We can
That's
give IV dexamethasone.
IV mannitol probably will work the fastest. Before the experienced consultant give the answer, you just think about your lecture. You talked about little head up position. You talked about mean arterial pressure. You talked about sedation. So all these factors are important. So you need to make the patient calm, quiet, see that the blood pressure is not high, see that I usually keep a 5 to 10 degree head up tilt for every patient, particularly an obese patient or respiratory disease patient. They have a higher venous pressure. You need to control that venous pressure, as well as you may have to give additional some sedation during that time. Because midazolam is a very useful drug, and we control the mean arterial pressure. These are the common things. But look for any tight band around the neck. Sometimes there's a necklace which is tight, so the venous pressure is high, and all those things you need to look for. And then, of course, mannitol will help. Now, Jai, question to you.
Yeah.
Anything
Actually,
else?
Yeah. So I have an interesting mnemonics to remember. If under local anesthesia, remember the term ABC VSR. Okay. What A stands for? Anxiety. B stands for bladder fullness. C stands for cough. V stands for vomiting. S stands for any straining. R stands for restlessness. So these are all some of the causes which you should remember if the patient is under local anesthesia. Suppose if it is under general anesthesia, the same ABC with EFR. What is that? A stands for any airway obstruction. What will happen? Again, central venous return will obstruct, choroidal engorgement takes place. Then bucking on the endotracheal tube, B. Again, C stands for cough. E stands for, as Rashesh said, endotracheal tube tightly fixed with the tape. That also again causes venous congestion. F stands for face mask. 2, if it is inappropriately fitting mask, again, IOP can raise retching. So these are the mnemonics which I often used to remember: ABC, VSR, and ABC, EFR for local and general anesthesia.
I wish you write down in the chat box so everybody will copy it.
And sometimes if the patient is light during
True.
the general
Depth of anesthesia in general
depth of
anesthesia.
anesthesia is very important. Sometimes
Very important.
if ETCO2 is more, then also there is hypercarbia can also cause the increase in
Very right.
intraocular pressure. So those things, and head up and hypertension.
Positioning.
So before mannitol, you see these things, because as soon as you will give mannitol, it will take some time to act. And many times mannitol is not in the OT. You will ask for mannitol, it will come. If it is a pediatric patient, then you will load according to the weight. So it will take time. Meanwhile, you can do all these things.
So first
Look
and
for other
foremost,
factors first.
treat the cause.
That's right. First, find out the cause which is raising it, and then try to give a therapeutic support like mannitol, because mannitol, again, you said bladder.
Yeah.
It's going to fill the bladder very soon. Yeah. And you have to be very careful in the dose. You don't use the actual dose which we use in preoperative control, or for control of glaucoma. We use a very low dose, bolus of mannitol, because the fluid bladder is going to give you problem in 10 minutes time in an elderly person on table, and he becomes more restless. So all these factors, few will be added by just giving mannitol. So I would rather.
And many times just change of surgeon will reduce many things.
Yeah, that is true. That is true. But we have limitations in those factors. Question for both. I mean, one of you can answer. Nitrous oxide controversy. When we don't use in ophthalmology?
When you want to try, or me?
You try.
Yeah.
Okay, you try.
So the nitrous oxide, they say it is about 34 to 36 times more soluble in the gases. What are the gases that they inject? Ophthalmologists is mainly they inject sulfur hexafluoride, SF6, or perfluoropropane, that is C3F8. These two are the gases which the vitreoretinal surgeons use for the creating tamponade effect. But unfortunately, what is happening? The nitrous oxide, what we use, is found to be 34 to 36 times more soluble when compared to nitrogen. So what will happen? Suppose if the surgeon says that I'm going to inject the gas, usually they inject at the end of the surgery. We cut nitrous oxide 15 minutes before the procedure. So this point you should remember. What will happen if suppose if you are using these gases, nitrous oxide can again diffuse rapidly into the gas bubble, and gas bubble size can increase. And what will happen? Automatically there can be a maximum rise in intraocular pressure, and as you said, that perfusion pressure will be reduced, and central retinal ischemia and optic nerve head also damages can occur, and patient can land up in complete blindness. And the other important point is, suppose if it in an emergency surgery, you ask for patient has undergone any recent retina surgery, and if they have injected gases, they say roughly around 2 to 3 weeks, nitrous oxide should be avoided. So these are the points we should remember, especially when you're using nitrous oxide. But of late, in many places, compressed air is now being used. That is a good sign for ophthalmic.
Yeah, we normally use air only. We don't use nitrous oxide. Probably.
Yeah, I want to comment.
Please. Yeah, I was coming to you only.
I read somewhere that these gases are not given only in the OT. They are given in the OPD basis also. It is called retinopaxy.
Yeah.
So there they have a band at on the hand, so that everyone will know that this patient is having gas in the eye. Wristband. So many times if road traffic accident is there or something else, there is no one to tell about the patient. The anesthetist will know and the other surgeons will know. And it has been seen that the patients who are having gas went for the surgery of some other things, and those are not knowing, and they have complete vision loss.
So this is most important.
Yeah. So for other surgeries also, one should ask any eye procedure. In OT and in the OPD, both places. So it is basically ophthalmologist's responsibility to tell the relatives or give something so that the other persons will know that there is a gas. And then another thing which I read, that usually they remain for 2 to 3 months, but until and unless then ophthalmologist do the indirect
Clears it.
ophthalmoscopy and say that now there is no gas in the eye. Till that point, nitrous should be avoided.
Perfectly described. There is an identification device like a pacemaker and all they are carrying usually when they put the gas. It is very important point you mentioned. Okay, one more question for you, Renu. That's regarding the oculocardiac reflex. You are doing a child under general anesthesia, the squint surgery, and of course you are doing the spontaneous respiration with the supraglottic device without muscle relaxant. You mentioned that in your lecture. Would regional anesthesia along with that will help to reduce the oculocardiac? That's a question.
Yeah, completely.
And you recommend that every time?
If in general anesthesia, peribulbar and subtenon both can be chosen according to the surgeon. But lately, my surgeon, they are not happy with the subtenon block once they are doing at the initial part of surgery. But if the patient is having repeated OCR, then giving even a 1.5 ml of local anesthetic in subtenon space will solve all the problem. So yes, if the patient is having OCR and it is not subsiding even after repeated stimulation, or if it is causing the heart rate reduction to too much, 40 or 50, then giving a subtenon, if you want to try, you can try Paracane. If it is not helping, then yes, subtenon block. If during the surgery, then peribulbar cannot be given.
Yeah,
but,
it is better to give subtenon block.
We have
now,
seen
in fact, I've seen, I've observed oculocardiac, even the child is paralyzed with non-repolarizing. It has nothing to do with relaxation. Is there pulling of the muscles can still generate oculocardiac, and very frequently it happens. And severe bradycardia also I have seen going into 40 from 110.
Yeah, I want to tell that I wanted to make a video of OCR, but for last 20 days I am trying, but no OCR is happening, and I was not able to make it.
You're lucky not to have it, because it's one of the most common complication in squint surgery.
Actually,
and you mentioned a very high incidence rate.
And actually, it is the surgeon who is handling the muscles. If they are trained, the incidence is less. If there is a new surgeon, incidence is more. So in every place, I think the experienced surgeons are there. So as soon as the heart rate is decreasing, they listen it and then they stop. So the extreme level of OCR is less in institute where the experienced surgeons are there.
And the postgraduate students must understand the first treatment is to release the stimulus. Wait for some time, because they're pulling the muscle, and you give atropine can create a lot of havoc. It can create a problem to us. So ask them to release local anesthetics, and everything should be used when I have seen it happening frequently on the same patient. So I have asked them to give the subcutaneous block and carry on with that.
Patients who are having craniofacial anomalies, and the patients who are preterm, the children who are less than 1 year, the chances, and they born preterm, we have seen that the OCR incidence is more in those patients.
True. Yeah. One more question related to pediatric only. I'll give a preference to you to answer. Is that's actually a tricky situation to do young babies with probing and syringing.
Yeah.
You know, the procedure is so minor, they take it very lightly. Even the seriousness is not there, even to the parents. And we are in stress when we have to do these procedures. The question is, do you prefer endotracheal intubation, or you do without that?
Not we use supraglottic device. We are fan of supraglottic device, and we use the first generation supraglottic device, not with this. So, and we put a suction catheter in the nose on the side where the syringing probing is done. So at the time of once they instill the betadine mixed saline, it will not go into the oral cavity. It will be sucked through the nose. So the chances which you can think of aspiration or other things, which is not there once you are having suction catheter in the nose. And as soon as the fluid is coming into the nose, you will also know. So it will both detect and will prevent aspiration.
So it's a very good tip. I tell you, you should not take very lightly, particularly this 1 month, 15 days, child also comes. And for probing and syringing, best is to use the number 1 igel. This is a very good tip you gave, keeping the suction catheter in the other nostril, and you can always change it when they do the other side. Usually they do the both the sides together, so it is always safer to put the suction catheter. Excellent tip you have given.
Actually, Dr. Ashish, for 15 days kit, usually they
do massaging.
So
Yeah.
basically 15 days kit comes once they are having cataract and they have suspected NLD block.
Yeah.
So they want to do the NLD first so that they can operate for cataract surgery early.
Yes. The
Because-
question is infection. That's why they do it
Yeah.
when their child is for the cataract. I mean, all postgraduate students and all the consultants who are attending this program, you will understand there are so many intricacies involved as a subspecialty of ophthalmic anesthesia. There are so many things which we are discussing, and there are 100 more things which we discuss whenever there is a full day, 2 days conference. So I think we need to learn a lot about ophthalmic anesthesia, and I'm sure this was a very good session. There may be 1 more 2 questions. I don't think there are more questions in the chat box now.
Sir, some
Okay.
medical legal question is there.
Yes, there's a question. You pre-CME, you discussed about medical legal issues regarding post-op loss of vision and anesthesiologist's role. Oh, that is regarding the either perforation or some complication, right?
Yeah,
Jai,
during block, yeah, complication. He's asking.
Jai, this is related to you. Is there any medical? Say now, I only said that anesthesiologist has taken over the regional anesthesia and ophthalmology in most of the ophthalmic institutions. At least I know Shankar Netralaya, RP Center, Evli Prasad Institute, my institute, Arvind Eye Hospital, even this Cochin Institute. Everywhere I have seen ophthalmologists giving the blocks. And in my place in Gujarat, even in the private practice, most of the ophthalmologists give the blocks. So do you like to answer?
Yeah, actually, the needle blocks per se is a blind procedure only. For that matter, complications can occur at any time. Until otherwise, there is a gross negligence in any part, patient suddenly moves, those things. More of this, I think, this question relates to non-ophthalmic surgical cases, especially if there is a spine surgery where the patient is put in prone position. There are cases of post-operative vision loss. And there is a medical legal registry also maintained in abroad, where there is a maintaining number of cases of post-operative visual loss following non-ophthalmic cases, and there are some medical legal issues going on regarding this. This is what I was wondering about this question. I never thought of penetration and perforation. So far, those things resulting in complete loss of vision I have not encountered. So we can explain to the patient that it is a blind procedure. It can happen to anyone, and we can ask the surgeons to do the needful for the patients.
Dr. Jay, Dr. Jay, you are telling the patient that there is a chance of vision loss while you are performing the
consent is there.
You are saying? You are saying?
Consent for local anesthesia, it is mentioned.
Oh, even then patient accepts.
So far, we have not encountered any such cases.
No, that's no, but it is threatening to the patient. The patient may be
very, one thing I must tell you, there is a lot to learn in regional anesthesia and ophthalmology, where you really need to see the good people working, how they safely do it. You need to understand the anatomy and everything so well. And most important, which point was not raised, was how you decide the volume you inject in the orbit. That's a very technical, and you need to have a very good prediction of this. I get a very good peribulbar with 3 ml, and sometimes I don't get even with the 12 ml. So what are the factors important for deciding the volume? Now, all these factors, if you keep in mind, and keeping the bevel towards the sclera while you are injecting, do not go beyond the posterior pole of the eyeball. You do not inject when you are at the equator of the eyeball, which is the widest portion and narrowest space between the orbital wall. All these things are very important. We teach in the workshops, in the hands-on. And then the complication rate is very high. Now imagine, this is where anesthesiologists has to come out of the mindset. You are one team, surgeon and anesthetist. Any complication can happen in intubation failure. You fail to intubate, something can happen. It could be life-threatening. It could be stroke or something can happen during induction. Surgeon has yet not touched it, but it's a teamwork and it's a joint responsibility. So this is part of it. So it's not because ophthalmology blocks were the domain of the surgeons and now we have shifted to anesthesiologists. We have to be worried about this. It's a teamwork and everybody is jointly responsible. And someday this can happen if it is your bad luck. And I tell you, any of the medical legal sessions when you have attended in last 20, 25 years, there is no end to the discussion on this. And you also know it well. Ophthalmic OT, Dipti Desai has asked one question. Ophthalmic OT requirement for medical issues? I don't get your question. Dipti, you can repeat the question.
No, she is asking for managing medical systemic emergencies.
No, she's asking the infrastructure about the OT. It is just like any other OT.
Just like any other OT.
Yeah. Because we take it as a small thing. We take it as a small thing, nothing will happen. That is a problem.
No, never take ophthalmic surgery lightly. That's what I told before also. And you need to be preparing, you need to have the proper training. You must have the comprehensive cardiovascular life support training as well.
Correct.
I'm ready to give it. And you should be fully equipped. Like I have a defibrillator with a pacemaker now for last couple of years. I can do transcutaneous pacing also. So I would suggest that you should have fully equipped like an medical or coronary care ICU in the operation theater, because imagine eye is a part of central nervous system. It's not a separate organ. It's a part of central nervous system and is always innervated with the autonomic system, which is we are always vulnerable to the complications. So you have to be very careful.
And Dr. Rashesh, nowadays, while we are doing so small kits for cataract surgery, for glaucoma surgery, 1 day, 2 day old.
Yes, 1 day, 2 day.
Surgery. So I will say that much more equipped than other OTs.
Very true, very true.
For handling.
We need fully.
Yeah. So, and much more.
It's almost 8 o'clock.
Yeah.
2-3 minutes left. I'm sure we had a wonderful discussion. There may be many questions now coming to the mind of the people after a lot of discussions. I'm sure they should attend the conference in Madurai next month in September. Unfortunately, I'm missing it because I'm in Germany during those days. But thank you so much.
One person has asked Dr. Rashesh, which local anesthetic is better for the block, lignocaine or bupivacaine?
Oh, okay. Actually, Jayachandra also mentioned it's a combination of 4 things I use: bupivacaine, lidocaine, hyaluronidase, and adrenaline. Everything I use for the blocks, but in a calculated amount. Jay, question is actually for you.
So lignocaine as such, I think it is a short acting, so post-operative pain will not be covered. So bupivacaine will be the better. But half late we are not started using ropivacaine also, which is much cardio stable. So I think ropivacaine is a very good drug of choice, and we have published a paper in the last couple of issues before in Indian Journal of Ophthalmology, comparing bupivacaine and ropivacaine for vitreoretinal surgery, where we found that ropivacaine is a better local anesthetic agent compared to bupivacaine in terms of efficacy. So I think ropivacaine we should go for.
We are also using ropivacaine in the place of bupivacaine now. It comes with 0.5 and 0.75%. The advantage of ropivacaine is that it is a vasoconstrictor in comparison to bupivacaine, but it gives less motor block than bupivacaine. So one should keep that thing in mind. So if your patient is cardiac patient, use ropivacaine. It is much better than bupivacaine. And lignocaine we mix because of the early onset.
Yeah. Second point is probably periverbal is the only technique where we use hyaluronidase as one more ingredient. It's the only regional anesthesia in the whole body where, because in periverbal technique, you do not inject the anesthetic directly to the target tissue. If you want it to go into the periorbital connective tissue and we want it to travel to the nerves, and that travel, we need the hyaluronidase. And probably when you use retroverbal, we don't use hyaluronidase, but for periverbal is the only technique where the hyaluronidase helps. But the only drawback of hyaluronidase is when you use hyaluronidase, the absorption of the local anesthetic is faster. So if you use only lidocaine, the block doesn't last long, and particularly the facial block wears off in 15 minutes if you use plain lidocaine. So at the end of the surgery, or sometimes surgeon gets a complication during surgery, the patient starts blinking, and that's where the rescue formalin block is used by the surgeon themselves. So hyaluronidase this problem. So that's why using epinephrine is very common in the ophthalmic block. And now ropivacaine, I have tried some, gives a good duration. But for the vitreal retinal surgeries, I still prefer bupivacaine with the lidocaine, etidine, and hyaluronidase, because sometimes it lasts more than 2 hours. And we need a very sound block till end of the procedure. Another problem with hyaluronidase is higher incidence of hypersensitivity. I have seen the pseudo-orbital tumor next day. They have ptosis, they have myotoxicity. All these complications are very commonly seen, but they are not serious complications. Just reassuring the patient and telling them next day that it will cover another 24 or 48 hours and it recovers. But I have seen, I've given a periorbital block with hyaluronidase on the right eye, and when the surgery was over after 2 hours, there was a complete ptosis on the other side, and there was a huge edema over the leads. So that's how the hypersensitivity spreads to the other side. Also, I have observed about 3 cases in my career with the hyaluronidase. But these are the non-complications. So if you are confident about that, there is no serious condition. They always recover. Anything to add and regional? Any more questions? I can see the stent had gone to 74 and started dropping down to 50. And if nothing more is there, I must thank particularly the academic wizard, Dr. Meenakshi Sundaram, for inviting all of us. Thank you so much, all the panelists, and England, the young buddy. Dr. Anusha, are you there still?
Yes.
Yes, sir. I'm there, sir.
Thank you so much, and I wish you all the
Thank
best.
you,
You
thank
are
you.
going to be a wonderful faculty one day to serve the Indian Society of Anesthesiology. Wish you all the
Thank you
best,
so much.
and I thank the office bearers of Indian Society of Anesthesiology also.
Thank you,
so
sir.
much.
Sir, thank you very much.
Thank
See,
you.
actually, as far as I'm concerned, personally, I don't know how many will be like me. My standards in ophthalmic anesthesiology will not even match the standard of Dr. Anusha. She is far better in that ophthalmic anesthesiology part is concerned. She is really good. And see, we just like a blind man describing the elephant. So many people would have thought ophthalmic anesthesia, it's so cheaper, it is very easy. But for those blind people, it is really an eye opener. And I can really say, with my eyes closed, if I recollect, it is excellent. It is marvelous. And if for 2 eyes, 4 faculty, it is just like a diplopia. But the diplopia has thrown so much of a light on so many, not only on the eyes of us, in the minds of us, you have thrown light, sir. Really, see, all the faculty are soft spoken. This time it is immensely, you have done some good thing, because even slowly, as we have crossed the 20th webinar, we are also improving, and the time you have well managed timing, all the people, and that has given a lot of time for discussion. Not pinpoint. See, even starting from Dr. Anusha, see, you 3, I need not say, but the timing sense, you are very perfect. The chairperson as moderator, as a person who is interested in academics, and as a conference B, I am seeing how calculative you are. The way in which you are discussing, all are soft spoken. The decibel was low. Matter was crystal clear. Intention is clear. You have known the ideology of Pudukkottai Buddha. That's what I want to say. No research point, no nothing. Even though you have so many papers, original papers, you have never mentioned anything about that. And even for the 2 eyes, I don't know how many people have seen 2 strabismus surgeries. It is very difficult. Majority of the people would not have even seen strabismus surgery. We know only cataract. And see, even the surgery could be imagined. The way in which he has explained, Dr. Jai has explained the anatomy, Madam has explained about the surgical procedure, When you have covered everything, it is excellent. And for the first time, the postgraduate have stuck to the timing. But at 10 minutes, this is the first time for
She
all.
was the best in my opinion.
Yeah, see,
She exactly took 10 minutes.
Out of all these webinars, she is the first one who has finished within 10 minutes. Another reason maybe we would have explained her 10 times. You have to stick to your time to 10 minutes and not more than 10 slides. So that is extremely good, sir. I thank on my personal capacity and I hand over the session to our president, Dr. Suresh Kumar. Sir.
Thank you very much, sir. ALM, sir. Very, very useful session, wonderful session. Everybody was thrown enough light on the topic. Very, very fantastic session. The ophthalmic anesthesia was discussed end to end and in full depth, basic and to all the practical aspects. As our treasurer David could not make it, I thank our chairperson Dr. Rajesh Diwan. With your soft spoken, evident and palpable throughout this webinar, on behalf of IMA, I profoundly thank you, sir, for navigating the session very wonderfully and fantastically.
Thank you, sir. Thank you very much, sir.
Thank you, sir. And my thanks to Dr. Jayachandran BV of Shankar Nethralaya. Very, very good topics, sir. Good slides, and your video presentation is very, very useful for our postgraduates. And personally, for me also, I have never seen the performance of this type of block in my life. And I thank our Dr. Renu Shinka, Madam, Professor of All India Institute of Medical Sciences, for your wonderful presentation and useful and very, very practical discussions, especially on pediatric ophthalmology, Madam. I thank all the three of them for making their time, your busy time, and allotting to Pudukkottai Budan. Making this session is a very wonderful one. And lastly, Dr. Anusha Bharatam, resident par excellent, wonderful, doing a topic very nicely. I thank our Dr. ALM sir, who made this session, selection of topics, selection of speakers, and selection of chairperson for this Pudukkottai Budan. Once again, I thank you, sir. I thank all the dignitaries who have come here watching this webinar, our office bearers, anesthesiologists, and postgraduates. Once again, I thank you all. And my thanks to the Acura group people who are giving academic support, and our people A1 Logistics who give technical support. Thank you. We'll meet in next webinar. Until that time, thank you. Namaste. Thank you.
Thank you so much.
Second webinar will be an ENT, sir. So they will be stressed now after seeing this. That ENT people. A1 Logics, you can end the meeting. Thank you all.
Thank you, sir. Thank you.
Bye, everyone.
Bye.
Done. Out. Very well done.
Now, but Dr. Meenakshi, I tell you, this is a wonderful gesture you are showing. Every week, one program is not a joke to organize such events and to get the speakers and to get it done in the way which you want. And really very beneficial to the postgraduates.
It is because of the
I wish more and more people utilize this and keep doing it forever, year and year after this.
Thank you very much, sir.
Bye. May I take your leave?
Yes, sir, please.
Thank you so much.
Thank you. Renu madam, thank you. Hello. சொல்லுங்க.